Welcome to the Dallas Area Gerontological Society 2020 Annual Fall Forum, the year everything changed. Our Vice President, Ms. Susan Rogers, is going to introduce our next speaker, who will be talking about trauma-informed care in the wake of COVID-19.
Hello, everyone. It's so great to, well, not see you, but know that you're here. I've seen some of you in the interactive exhibit room, so that's been fun. And I'm going to give our next speaker a moment or two to present her slides using the share screen tab. And while we're doing that, I will introduce her. Carren Zygerfuss is a licensed clinical social worker and a certified clinical trauma professional. She earned her master's degree in social work from the University of Pittsburgh and also has a bachelor's degree in criminology. Carren is a U.S. Army veteran and has worked and volunteered within the military and veteran communities for over 20 years. Carren has worked with survivors of trauma throughout her career, including domestic violence, sexual assault, sex trafficking, adult survivors of child abuse, military service members, veterans and their families, first responders, and other populations. Carren has training and experience in cognitive processing therapy for post-traumatic stress, dialectical behavioral therapy, cognitive behavioral therapy, and motivational interviewing. Carren practices at Ranch Hands Rescue, a human and animal sanctuary in Argyle, Texas. Ranch Hands Rescue is the first organization in the world to partner rescued farm animals that have experienced abuse and neglect with clients in deep psychotherapy counseling sessions. The counseling center provides unique trauma-informed counseling to people with a wide variety and wide range of mental health issues, and especially those who've experienced deep and complex trauma. So with that, we are honored to have Carren here talking with us, and we'll turn it over to you.
Hi, thanks, Susan. That sounded really intense. That was from our website, a lot of that. So thank you so much for having me. I really appreciate it, and I'm glad to speak with everyone. I have some experience working with the geriatric community. I worked inpatient psych for about 14 months, and we had a geriatric ward. And so I did work in that arena for a little while. And I've done some individual and couples and family therapy with people over age 65 as well. So I have some experience with the older population. Today, I want to talk a little bit about trauma-informed care, and my focus really is going to be about relationships, and not just relationships with patients, but with your colleagues and taking care of yourself. I was asked to speak a little bit about how to give some pointers on self-care and caring for each other, and also caring for patients with the knowledge, a little bit of knowledge about what trauma-informed care is. And with COVID-19 and everything going on with that, there has definitely been an increase in the stress of those of you who work the front lines, especially day in and day out with your patients, and all of the different types of facilities that y'all work in. And I'm sure that many of you have just been working around the clock without much of a break. And I commend you for that. I really do. I can't imagine what that is like for y'all right now. And so in your personal lives too, I mean, there's just so much going on. And COVID-19 has brought on a lot of trauma as far as how people have experienced it, just in their own personal lives, and then adding our professional lives as well. And so that's kind of what I'm going to talk about. And so I don't have a lot of time, to really go into a lot of this. So as I'm talking, if you have questions, if you'll put them in the Q&A box, and at the end, I'll try to have a few minutes to answer questions along the way. So I might speak a little too fast. So if you need me to repeat something, if you'll put that in the chat box or the Q&A box, and the moderators will help me out here. So, because I can't really see those. And so anyway, I just want to do a quick poll at the beginning and ask y'all, how many of you have had some type of training in trauma-informed care? Before today?
So if you'll type that in the chat, I'm seeing a couple of nuns. Oh, I have one yes.
Okay.
Two yeses. And a sum. 2 yeses and a sum. Oh, we have a yes lots. But the vast majority are nuns.
Okay.
Still coming in. So yeah, mostly nuns. It looks like there were a couple that had either some or just said yes.
Okay. So we're just gonna do like a toe dip into trauma-informed care. I'm gonna kind of introduce you to it a little bit today. So I'm gonna go to my next slide. And so I got this wonderful little spur of knowledge here from the Child Trauma Academy there at the bottom. And so if you want more information about trauma-informed care, and talking about the neurobiology of trauma, especially in children, and really about it is an amazing website with some great articles about the neurobiology of trauma. And what I want to explain is that trauma can start in the womb. And when a fetus is growing inside the womb, that's where trauma can begin. And it's we would be here forever if I went into all of that, and I am not a neurologist or a neurobiologist, so I don't even want to try to do that. But I want y'all to understand that trauma can begin before a child is ever even born. And our brains develop in the womb, obviously, and continue to develop for a very long time. And the neural pathways that develop in response to sensory input. Okay, so in the womb, if the sensory input is arrhythmic, meaning there's a lot of things going on outside of the body that is traumatic to the womb, whether there's or inside the body, whether it's drugs, alcohol, could be nicotine, maybe the woman is being abused and the fetus is in the womb, or the woman has a lot of stress and anxiety, panic attacks. I mean, there's a lot of different things that become arrhythmic inside the womb. So the brain of the baby begins to develop these neural pathways that are arrhythmic, and that's how the baby can become sensory, what's the word I'm looking for? Sensitive. My brain's not working. I'm talking about the brain, and my brain's not working. But the sensory input is arrhythmic, and therefore the child the fetus develops these neural pathways that kind of go into like this survival mode because of the arrhythmia. And so I just want you to kind of understand that even before a child is born, they can develop these neural pathways that are arrhythmic, and trauma can begin. So it doesn't always start that way, but it can. And so even when a child is born and as they grow, the behaviors that we might see, we may not realize that things happened while they were in the womb. And I know y'all work with the elderly, but I just want you to know that things can begin very early in life. And if they're not treated properly or they're not recognized, then of course they carry on throughout their life. So that's where they talk about the rhythm, and whether it's rhythmic, it's predictable, or it's arrhythmic, unpredictable, survival mode, things like that. And then talking about relationships, and that's a lot about what we're going to talk about today, is connection and relationships being that vehicle for change when we need things to change so that a person can live a healthier life. I hope that makes sense. So the importance of human connection. When we are born with the innate need to connect with other people, with other humans. And when a child is neglected from their parents, it can have a worse effect than neglect, whether it's emotional neglect or physical neglect or both. It can actually have a worse effect on the child than physical abuse, depending on the level of neglect. And studies have shown that. I don't have all of the resources for that, but studies have shown that neglect can sometimes have a worse effect. And so when you think about this type of trauma in a child, whether it's neglect or physical abuse, sexual abuse, any kind of abuse or neglect, and then they go through life, and then now you might have one of these adults, these seniors in your facilities that you're working with, and you don't know that they may have experienced some of these things in their life, or whether or not they've ever had proper treatment. You know, there may be things that you say or that you do that could trigger them, or that could be very disturbing to them, but to you, you don't know that, and you don't realize that. And so sometimes there might be some sort of reaction or something that they have that you're like, what did I just say? What did I just do? And so asking them or talking to them about, you know, hey, did I say something that upset you? What happened? Things like that. And we're going to talk more about that. And I just want to throw this out there. This picture is me and my son 20 years ago. Just throwing that out there. So anyway. Okay, so connecting with your patients, as Dr. Rossetti just totally set this up for me, because she was talking about seniors in isolation and dementia and the effects of isolation, and how it can, make dementia worse even. And as you know, isolation, even without COVID, is a big problem for our senior population. And it can lead to, major depressive disorder and very depressed patients. And our senior population is one that is at one of the populations that's at the highest risk for suicide. And a lot of that has to do with the isolation and depression. And major depressive disorder is someone with that diagnosis is most at risk for suicide. Because the depression can become so severe. And so our senior population, we really want to make sure that we're connecting with them, especially during COVID right now, and understanding that you still have to maintain your professional boundaries, and I totally get that, but you want to connect with your patients, especially when their families can't connect with them right now the way that they used to, because they can't come and see them. And so knowing your patients, when I say knowing your patients, what are their normal behaviors? What are their normal activities? And, normal is relative, but when, if you know your patients well enough, and when they're not acting like they usually do, or they aren't, maybe they have a certain routine and then they're out of routine, then you want to start to talk to them and communicate with them, and hey, is everything going okay? I've noticed that you're not eating like you usually do. Are you okay? Now, I do understand that some of you may work in some places where you can't the patients can't verbally communicate with you based on their level of functioning. And maybe they can't even feed themselves, things like that. But you still are able to know what is their normal routine. How do they typically behave? Do they eat when you feed them or when somebody feeds them? Maybe they have a feeding tube, but knowing their behaviors, knowing what's normal for them. So find some way to communicate with them. Maybe they use eye blinks, one for yes, two for no, things like that. Just finding ways to communicate. We can't really communicate with smiles right now because everybody has to wear a mask, but just finding ways to communicate and connect with your patients is very, very important, especially during COVID. And then when I'm talking about all behavior has meaning, so if you have patients that are, typically they're pretty calm, chill, relaxed, or maybe they don't move a whole lot, but then suddenly one of your patients maybe reaches out and grabs your arm, or tries to reach out and grab your arm, or they become suddenly agitated or something like that, and it's atypical of their behavior, there's probably something going on with them. And instead of us just suddenly going, oh, Mrs. Johnson, she's being aggressive, we need to give her medication and calm her down, which in my experience working in a psych hospital, that's typically what everybody did was, but I know that hopefully that's different in where you're working. But instead of thinking automatically, Mrs. Johnson, she's being aggressive, we need to give her medication to calm her down. Well, maybe something's going on with Mrs. Johnson. That behavior of suddenly reaching out and grabbing your arm, or maybe becoming agitated, something's going on. So try and communicate with her, asking her if she's hurt. Maybe she has a cramp of some sort. Maybe she has a stomach ache. Something's going on. Maybe she's scared. If she can't communicate verbally, try to communicate with her non-verbally in some way. So instead of just assuming it's aggression, try to think of it differently. Think of, not necessarily maybe it's a trauma, but something's going on because it's atypical. It's arrhythmic. I hope that makes sense. I'm going to move on. Okay. Relationship is the vehicle for change. That was on the square about talking about the trauma-informed care. Okay, now I'm going to address supervisors, managers, directors, those of you in leadership. Just like I was talking about knowing your patients, leaders, you need to know your staff. You need to know what's normal, typical, behaviors for them. You need to know when they're not performing like they normally do. If somebody's coming in late, for instance, all of a sudden, and that is not typical of that person usually comes in early, and suddenly they're coming in late, maybe something's going on, at home, or just something in their personal life. And so instead of calling them on the carpet and yelling at them, have a conversation. Call them in and say, hey, I noticed you've been late a couple of times in the past 2 weeks. Is everything okay? Is there something going on? Is there something I can help you with? Different leaders have different leadership styles. Believe me, I know that. I've had different types of leaders. My leadership style is more of a, come into my office, tell me what's going on. But, know your staff. Know when things aren't going right. Know when the atmosphere and the morale is not going well. And, do a morale check. Check in with people. Say hi to your staff in the morning. instead of just walking straight to your office. You know, you'd be surprised how much that means to people, just to walk around and know their names. You know, it's so important. If you want people to respect you and you want people to do their jobs well, know your staff, communicate with your staff. And, you know, what do they need to be successful? Listen to your staff. If things aren't going well, know your staff. That relationship with your staff is that vehicle for change. Okay, I'm just throwing that out there to leadership, all right? Just want to make sure I touch on that too. All right, colleague to colleague support. Okay, so just like I was talking to the leadership about, you know, instead of calling people on the carpet saying, hey, you know, I've noticed you've been late, etc. So these are some things that you can say to your colleagues if you notice a change in behaviors. You know, I've noticed, and then you can talk about the behavior. Hey, I've noticed you've been coming in late. You know, is everything okay? I'm concerned about you. You know, I just want you to know I'm here for you. Is there anything you'd like to talk about? And, I mean, these are some sample questions that you can ask. And if they tell you, you know, I've just been feeling so overwhelmed, or I've been feeling depressed, or I've been feeling this way or that, you can, how long have you been feeling that way? And, you know, you can ask them some questions. Now, when you ask the questions, you're asking the questions to show that you care, because you want to see if they're doing okay, and you want to see how you might be able to help them. And I'm going to show you that on the next slide. But I'm not saying ask the questions so that you can fix it. That's not the idea. You're not there to fix it. You're there to try to listen, and just listen non-judgmentally. Okay? We have a tendency as humans, a lot of us, to want to fix it. And if you're a fixer, try to keep your mouth shut, you know, and just listen. Okay? Because we want to be heard. Humans want to be heard by people. We just want to be heard. I know that. And so sometimes you just need to ask the questions and then be quiet and just listen. And sometimes you might ask a question. You know, I've noticed that you just don't seem to be yourself lately. You know, you're just kind of moving slow, and you just don't seem to have the pep that you usually do. Is everything okay? And the response might be silence. They may not say anything right away, but they don't walk away. But just be okay with the silence. Don't continue to drill them with questions, because they're thinking, right? Has anybody ever asked you a question like, are you okay? And you're like in your head, you're like, I don't even know how to answer that question. Well, other people get that same feeling. So just be okay with the silence, okay? And the other thing I just want to mention, that when I say, is it okay if I just sit here with you? What I mean by that is sometimes you just need to be present with the person that you're talking to. Just be present. It is really helpful sometimes to just not say a word, but just be present and show the person that you're there. That can really go a long way sometimes for somebody else. So here are some things that you can offer as support, you know, or some ideas, you know. Hey, when was the last time you saw your doctor? You know, maybe get some blood work done, and get your, you know, maybe you're low on iron or certain vitamins and that kind of thing, you know, getting a blood panel done. Professional counseling is another resource. I mean, that's what I do for a living. Faith-based counseling, if you happen to know that person is of a particular faith and that's really important to them, you might suggest that. You might suggest that they see a psychiatrist. I wouldn't go to that first. I would start with the family doctor, But maybe you already know that they have a psychiatrist, and hey, when was the last time you saw your psychiatrist about your medication? And maybe there's something that needs changed. And that's if you know that they already have that. Have you talked to your friends or your family about this? Is there somebody you trust that you can talk to? Self-help books, some people like those, some people don't. You know, that's something else you can offer. You know, those are just some ideas that I have. The list could be much longer, but starting with the family doctor can be the safest route. The family doctor can also provide referrals for other places. How am I doing on time, Susan? I have no idea what time it is.
We've got about 3 minutes left, and I know you've got about 3 slides left. So,
Okay, I'll rush. I'm running. Okay, self-care. As you know, take care of yourself. If you're not taking care of yourself, can't take care of other people. So I'm not going to read this slide to you, but these are things to think about, some questions to ask yourself, okay? And the slide before, these are things that you can do for yourself as well, okay? It's not just for your colleagues or your friends. These are things you can think about doing for yourself. So thinking about self-care and starting a self-care plan is something that you can do. And what I mean is start somewhere, pick something different, do something different, just pick something and start it. And I gave you some examples here of things that you can do. This is something that I am not the poster child for self-care. Believe me, my family will tell you the same thing. But I have been doing a lot of things for my physical health this year and taking care of my physical health that I needed to do for a long time. So I'm trying, and that's all you got to do is try. So these are just some ideas. And that's the last slide.
perfect. Perfect. We still have 2 minutes, and we have a question from our audience.
Okay.
And this was asking about what suggestions you have to help a dementia patient do something they don't want to do. So, for example, showering. And I remember when I worked in a memory care community, and there's one lady I'm remembering specifically. You know, our staff was trained to have a pretty calming approach and try to set things up, you know, nicely in the bathroom or in the shower room, and maybe have some soft music going on, or maybe don't have the person undress all the way. So they were taking some approaches to try to make that experience less stressful for a person. However, we had this lady who had really like a catastrophic response to us trying to have a shower with her and getting undressed and all of those things, and so our assessment really was, it seemed like she had had some trauma, that, you know, she has dementia, she can't express what had happened, but it was coming out now that she was in a situation where she kind of had a loss of control. And so in situations like that, what suggestions do you have for folks who are working with someone who may have trauma but is not able to express that because of dementia or other conditions?
So if they're not able to tell you, then I would probably, and if they're having such a catastrophic response, you don't want to make it worse by any means. And so what I would find an alternative way to bathe her, you know, for sure. If she has family that may know like why she was reacting that way, or may know her history, just to help you understand, then I would maybe try to find out a little bit about the history and see if anybody knows kind of what happened or why she might have that reaction.
Right.
But I wouldn't force the shower in any way, shape, or form, because that'll just, it will make it so much worse.
Compounds the trauma.
Oh,
Yeah.
absolutely.
Yeah.
Absolutely.
Yeah, so I think flexibility and creativity there. We had a comment from Angela Thomas saying personal care can be done without having to take a shower. And so, right, like you said, take a different approach and find an alternative. So thank you so much. I know that, we did not have a lot of time. We could have delved into this a lot deeper, and we really appreciate your perspectives on this, on how we can help our clients, how we can help our colleagues, and how we can help ourselves. So we really appreciate you and hope you'll stick around a little while.